Dear doctors, good afternoon to one and all who have joined this session. Today, we are here for the continuation of first two sessions by Dr. A.G. Unnikrishnan and Dr. Jyotidev Keswadev under program outreach in collaboration with RSSDI and ABBOT. We welcome you all to this third session on guidelines and consensus recommendations on diabetes treatment and glucose monitoring and how it impacts in your clinical practice. The speaker for today's session is Dr. Banshi Sabu. With his huge expertise in this segment, I would like to brief you about Dr. Banshi. So Dr. Banshi is a chief diabetologist and a chairman of DiCare, Diabetes Care and Hormone Clinic at Ahmedabad. He is honored with fellowship of American College of Endocrinology, American College of Physicians, International College of Nutrition, Royal College of Physicians, MN, AMS, Diabetology. Okay. So below are the some of the doctor's achievements. So currently, doctor is a member at International Diabetes Federation, the chair-elect for Southeast Asian. Doctor was a immediate past presentation of RSSDI. RSSDI is a research society for study of diabetes in India. You all might be knowing. Doctor was also president of AIAARO, Indian Obesity Society, from 2016 to 2020. He was an honorary vice president of Diabetes in Asia Study Group. Doctor was also an honorable secretary of Diabetes India. Doctor has also launched a project, Diabetes Free India 2030, which is acknowledged by Honorable President of India, Shri Pranab Mukherjee. Doctor is also a founder of NGO Diabetes Care India and India Sweet Registry Project. He is the owner of Eco India and Indeed, which is at Ahmedabad. Doctor is a managing director for Sadiko's International Textbook of Diabetes. He is an advisory board member of JAPI, Journal of Diabetology. He is an expert of RSSDI guidelines for management of diabetes, ATTD CGM guidelines, ISPAD guidelines for pediatric diabetes. Also, Doctor has numerous publications in Index Journal and have contributed chapters in various textbooks and monogram. He has awarded most impactful healthcare leaders by World Health and Wellness Congress and awards. He has also undertaken many public awareness projects under Diabetic Care India, such as RSSDI, Defeat Diabetes Campaign, KADM, that is Knowledge-Based Diabetes Awareness Movement, as well as IDEA, that is Intensive Diabetes Education and Awareness to Stop Heart Attacks. So with great honor, I would hand over this session to Dr. Banshi Sabu. I request all the participants to post any questions in the chat box. We shall address them at the end of this session. Thank you. Over to you, Doctor.
Hello, dear friends. I am Dr. Banshi Sabu, immediate past president of RSSDI. This module, which has been created combinedly by ABBOT and RSSDI, with the two session which is already been completed by Dr. Unnikrishnan, the introduction to continuous glucose monitoring, and by Dr. Jyotidev, the eminent technology man of our country, who had talked on patient empowered, customized based on patient needs CGM solution. It was in last outreach program, which was done on 16th December by Dr. Jyotidev. What I am going to talk today on guidelines and recommendation of continuous glucose monitoring. We will be taking what the international guideline is talking about the continuous glucose monitoring, what's the recommendation, and what RSSDI is recommending to India. This program is intended to increase the awareness of uses of technology in our country, particularly continuous glucose monitoring by our physicians. So thank you, ABBOT, and thank you, RSSDI, for giving me an opportunity to talk on a current guidelines and recommendation with continuous glucose monitoring. In the previous module, we looked at the clinical evidence for the role of sensing technology in managing diabetes, an overview of real-world data regarding sensor-based monitoring from India. We also talked on expert tips on getting started with continuous glucose monitoring, and then how to transition patients who are on self-monitoring of blood glucose to a sensor-based continuous glucose monitoring. What I'm going to talk in next 25 minutes, review the recent changes in international guidelines and recommendation, the key highlights from RSSDI 2022 clinical practice recommendations, overview of recent consensus paper which is related to continuous glucose monitoring, adopting everything into our daily practice, a case-based scenario, and then I will summarize my talk. The international guideline and a consensus recommendation. This is a paper in 2019 by Tade in Diabetes Care. I was one of expert for this consensus, which happened in 2018 and then we published in 2019. It is in time in range and ambulatory glucose profile report to facilitate the development of safe and effective care plans for patients with diabetes. Why it was needed? For a glycemic matrix, because we want a patient to have more in time in range in checking overall glycemic status to assess the time below range, time in range, and time above range, the glucose level. And first, we should focus on a time below range, which is focusing on addressing the hypoglycemia. The third part is review the complete ambulatory glucose profile, which will give us the idea, the glucose variability. And we have to modify the lifestyle and optimize the treatment design in such a way that we decrease the time below range. We try to achieve more than 70% of the time in range and time above range, as well as the variability, glucose variability can be significantly minimized. This is the complete idea of lifestyle modification and changing the treatment design also. The international guideline is being supported by multiple diabetes society across the world. And what they are saying now, along with HbA1c, it is time in range is also very, very important. This consensus was endorsed by ADA, American Association of Clinical Endocrinology, American Association of Diabetic Educator, European Association of Study of Diabetes, even by FAND as well as by SPAD2. The time in range are both appropriate and useful as a clinical target. So time in range below and above, it's very, very important target. And outcome measures that complement A1C, because A1C is an average of last 3 months. The each incremental 5% increase in time in range is associated with clinically significant benefits for individuals with type 1 and type 2 diabetes. So even with 5% increase in time in range actually gives you clinically significant benefits. The targets values should be considered as an integral component of continuous glucose monitoring data analysis and a day-to-day treatment decision making also. The ADA 2023 in their clinical practice guideline for the assessment of glycemic control, what they are saying that glycemic assess is assess glycemic status by A1C or by other glycemic measurement at least 2 times in a year. 2 times in a year, those who are relatively well controlled. In a year, who are meeting the treatment goals. Assess the glycemic status at least quarterly, which is every 3 months. If patient is not under good control, or those who are having therapy has recently been changed, or those who are not meeting their glycemic goal. Now, when glucose assessment, when we are doing continuous glucose monitoring, what ADA in 2023, they are saying that standardized single-page glucose report from continuous glucose monitoring device with visual cues such as AGP should be considered as a standard printout for all continuous glucose monitoring devices. Time in range is associated with the risk of microvascular complication and should be an acceptable endpoint in clinical trials for assessment of glycemic control. Additionally, time below target and time above target are also very useful parameters for re-evaluation of treatment design. In 2021, the American Association of Clinical Endocrinology, they are putting in their guideline the use of this advanced technology for management of diabetes. What they are saying that CGM is recommended for all persons with diabetes who are treated with intensive insulin therapy or those who are on insulin pump, all individuals with problematic hypoglycemia, either frequent or severe hypoglycemia, nocturnal hypoglycemia or hypoglycemia unawareness, or children and with children and adolescents with type 1 diabetes. Even pregnant women with type 1 and type 2 diabetes and women with GDM on insulin therapy. CGM may also be recommended for women with GDM who are not on insulin therapy and on insulin therapy, and individuals with type 2 diabetes who are treated with less intensive therapy. They can be also continuous glucose monitoring can be used for them too. to know the time in range, time above range, and time below range. So this implementing this international consensus on time in range recommended in a clinical practice case, because time in range in a percentage is a dynamic measure of a short and a medium term glycemia. It is easy to track. It can be visualized in a very meaningful way. It can be very personalized, provides information that is directly actionable. It is responsive to changes in diabetic management that can be viewed in a real time. It is allow smart objective to be agreed when goal setting, can be visualized and interpreted either as a percentage figure or as an absolute number of hours per minute per day. It better reflects the day-to-day expertise of living with diabetes than A1C, and it provides for different and more positive messaging for people with diabetes. There are key considerations, as there is a limited data to link improved with percentage time in range with reduced risk of micro and macrovascular complication of diabetes. It is important to acknowledge that a small improvement of 5 to 10% in time in range can deliver significant glycemic benefit. Women with type 1 diabetes who are pregnant or planning a pregnancy must be supported to reach a percentage time in target as early as possible during pregnancy, even before planning the pregnancy too. During pregnancy, the percentage time in range should be considered in conjunction with mean daily glucose, which is aiming for mean glucose of 108 to 170. The time in range should be used in conjunction with AGP data for a fuller picture of glycemic health as a basic for managing therapy and with making treatment decisions. Achieving a good percentage of time in range outcome between 70 to 180 should not come at the cost of increase in time in below range. So by any means, you should not try to just improve the time in range, not at the cost of increasing time below range, because we don't want by any condition one should go in hypoglycemia. These are the use of time in range in our clinical practice where the strength and key consideration are. This is in a very graphical way, you can understand the time in range in the targets. If you just see on the left side, the type 1 and type 2 diabetes, any patient, we should try to achieve a target of more than 70% of the time in range. It is not acceptable someone to go below 70 for more than 5% of the time. That is, and it is not acceptable even for more than 1% of the time if some sugar goes less than 54. For stage 1 hyperglycemia, not acceptable for more than 25% of the time, which is 180 to 250, and more than 250, it is not acceptable. Someone is going more than 5% of the time. So this is what a routine recommendation for any type 1 and type 2 diabetic patient who is using continuous glucose monitoring, and we can say what is the target time in range. But those who are elderly, high risk, who have high risk for hypoglycemia, this target range, which is between 70 to 180, even not for 70%, but more than 50% time they should also achieve. But it is not acceptable for them to go for hypoglycemia even for less than 1% of the time. So this is very, very important. And less than 50% of the time, they should not go more than stage 1 hyperglycemia. And similarly, they is not allowed for more than 250 milligram also by more than 10% of the time. Those who are with pregnancy and type 1 diabetes becoming pregnant, particularly, or type 2 diabetes, but particularly type 1 diabetes becoming pregnant, this becomes more tighter. The glycemic control time in range is 63 to 140, not up to 180. And more than 70% of the time they should achieve this. Otherwise, same, less than 5%, they can have hypo, which is less than 63, but not acceptable more than 1% of the time if they go less than 54. And less than 25% of the time, their sugar not go more than 140. So this is for pregnancy with type 1 diabetes. But what about type 2 diabetes who are becoming pregnant or true GDM patient? The target is again very tight, which is 63 to 140. But here we want almost like 90% of the time. The 5% of the time they can go less than 63, but it's not acceptable more than 1% of the time they are going below 54, and similarly not more than 5% of the time in a day. This is not acceptable if they go more than 140 milligram per day also. So the recommendation for interpretation of clinically meaningful differences in time in range, a difference of more than 5%, which is absolute percentage points in time in range, is considered clinically meaningful for individual participant in a clinical study, and 3% is considered clinically meaningful for treatment group difference in a mean time in range. The change in time in range should be reported separately for each study group from beginning to end of the study, and the difference between the study group should also be compared statistically with adjustment for the baseline period. Studies can be powered to detect a minimum 3% change in mean time in range between the study group. Section 2, which is Indian Clinical Practice Guideline and the Consensus Recommendation. If you see the RSSDI ESI Clinical Practice Recommendation for the management of type 2 diabetes in 2020, the CGM including AGP should be considered in conjunction with SMBG and SGNC for glycemic status assessment in type 2 diabetes individual treated with intensive insulin therapy who are not achieving glucose target. CGM may be considered in women with GDM or pregnant women with type 2 diabetes as a supplemental tool to SMBG in individuals with hypoglycemia unawareness or frequent hypoglycemic episodes. CGM should be preferably be used daily to gain maximal benefit. CGM can be a helpful tool in diabetic education by facilitating effective communication between clinician and patient, and all users should get trained on how to interpret and respond to their glucose data. Only continuous glucose monitoring system with an acceptable level of sensor accuracy should be used, and when assessing hypoglycemia, the accuracy of CGM data in the lower glycemic range should also be considered. This 2022 guideline is talking clinical practice guideline for CGM. CGM is recommended for patients with history of severe hypoglycemia, hypo unawareness, or patient at risk of hypoglycemia, patients who are with occupational risk with enhanced possible risk of hypoglycemia, like driving or operating hazardous machinery, infants and child receiving insulin therapy, patient receiving basal bolus insulin therapy with multiple injections per day, patient receiving sulfonylurea or glenites, patient with irregular schedules like skipping the meals, small meals, vigorous exercise, travel between time zones, disturbed sleep, scheduled shift worker, they should be put, and a pregnant patient. The real-time CGM alone is not recommended for glucose management in intensive care unit and an operating room until sufficient evidence demonstrates its accuracy and safety. Real-time CGM device is recommended in adult patients with type 1 diabetes, irrespective of any values who can afford and use these devices on nearly daily basis. For type 2 diabetes, CGM is widely used to evaluate effectiveness of different therapeutic approach in management of type 2 diabetes and also to compare the effectiveness of different oral hypoglycemic agents. CGM is widely used to assess other issues related to type 2 diabetes as to evaluate frequency and severity of the dawn phenomena in non-insulin treated type 2 diabetic patients across different age categories. CGM device have been used to assess the effect of acute psychological stress in type 2 diabetes. May be benefit in adult patient with diabetes to detect nocturnal hypoglycemia, the dawn phenomena, the postprandial hyperglycemia, and assist in the management of hypoglycemic unawareness when significant changes are made in their diabetes management or design in instituting new insulin or switching the patient from multiple daily insulin injection to the pump therapy. The recommendation continues with the CGM in type 1 diabetes. It is recommended for almost everyone who can afford and they can use it continuously for a pediatric patient as well as for adult. Type 2 diabetes, those who are on hypoglycemic agent, it is strongly recommended. For type 2 diabetes who are on low risk, still it is based on treating physician discretion because they want to know about the effect of food and to educate the patient. And for gestational diabetes, also it's a very important and educational as well as teaching tool for the patient. The consensus statement of use of ambulatory glucose profile who are on oral anti-diabetic agents, if disparity between fasting in ppbs and HbA1c is high, they should be. If they are on the risk of developing hypoglycemia, they should be. A patient who is not able to achieve this tight glycemic control, particularly patients who are at the risk of hypoglycemia, who have microvascular complication, who have concomitant infection or a macrovascular complication, first and foremost, very important thing, we should decrease the risk of hypoglycemia. And the time below range, which is up to acceptable 5%, that becomes even less than 1% of the time to go below a certain level, which is 70. A review by expert panel for South Asian population, a change in the lower limit of time in range can be considered. So instead of 70, should be considered 90 because they are more at the risk of hypoglycemia. Upper limit, this should be also considered when it is more than 250, but they are not saying what about the level 3. The flexibility in the percentage of time in range for pregnant women with GDM1 type 2 diabetes and customization of frequency of repeating CGM in routine diabetes care for the assessment of time in range. What's the benefit? As I told you, the benefits are hypoglycemia and awareness can be detected, determine the effects of high glycemic index. That's very important because that becomes very educational tool for them to change their lifestyle. And it's an educational tool for patients to understand their diabetes better, the ownership towards managing their lifestyle. How do we translate the recommendation into our clinical practice? Get comfortable first with different CGM options and features. Identify how to pair the person with diabetes to CGM, whether that is right or not. Address potential barriers when onboarding and sustaining CGM use. Exhibit comfort with prescribing and providing education on the use of CGM. Apply skills in data download and interpretation, and explain data outcomes with persons with diabetes.
So we are showing some of the clinical cases where we had used ambulatory glucose profile or this continuous glucose monitoring using Libre Pro in our clinical practice. I just give an example of a patient where we had used alpha glucosidase inhibitor. We know from the data from Western part of the world, which they are not using more of alpha glucosidase inhibitor, and shown that A1C reduction with AGI is roughly between 0.5 to 0.6 only. While in India, we had shown that actually AGI is working very well. The A1C can reduce up to 0.8 to 1.2. And this data, which I just want to show you, here this patient who is coming with an uncontrolled diabetes is already on a triple drug. And you can see that patient was advised to start insulin. And that's very true that most of the time with a patient with a triple drug with A1C of more than 8 or 8.5, an uncontrolled diabetic patient should be started on insulin. But what we have done is we asked the patient, let us do your continuous glucose monitoring. And this AGP graph is showing it is the post-meal glucose level which is high. Yes, the fasting was also little more. And what we have started this patient only on alpha glucosidase inhibitor. Started with lunch and dinner, the AGI, and then you can see the other reports had come normal except the post-breakfast. Good nutrition counseling and no carbohydrate or less carbohydrate or a complex carbohydrate in breakfast, lunch and dinner. And then we added it, made it 3 times daily. And you can see the last part of the report. It's absolutely well controlled. Rather, we had to decrease the dose of sulfonylurea. So this patient is only on sulfonylurea, metformin and voglibose along with gliptin. And this is long back. It is almost like 6-7 years back. I had shown this paper somewhere that how the AGI can be very effectively controlling the sugar, not only controlling the sugar, the glycemic variability also. One more example which I would like to give here, that only by changing the diet also. This is a patient of actually pre-diabetes population with a borderline diabetes. You can say sometimes his HbA1c used to come 6.4, even sometime it had come to 6.5 and 6.6. Also, what we have done is, let us see your the report of continuous glucose monitoring. Patient was already started with metformin, and what we had seen, it is still the post-meal glucose levels are high in between. And we just explained the patient that how the post-meal glucose, if we just change it to the diet only, the low carb, the high fiber or high protein diet, if we add in your diet and we change your diet pattern, you can achieve a tight glycemic control even without adding any other molecule, and you can achieve a very good control. It will help not only for your weight reduction, but a glucose control can be done from an average of 165 to almost like 119. So that sort of a sugar can be controlled only by diet counseling. And this also become an educational tool for the patients, and rather I will say motivational tool for the patient for his diet compliance too, because that patient will understand that by increasing the carb content in the diet will increases his sugar level, and that will also going to increase the sugar weight also. So only by changing the diet pattern you can have a tight glycemic control. This is one more example which I would like to give, and this we have done in 2018, one of our patients. The other, this is again very, very interesting. The patient was already on a dual drug rather. It's a sulfonylurea with metformin with very, very high sugar level. Control was almost like a 10. And we explained the patient that there is a GLP-1 which is injectable. But before putting you on insulin, I think we should try that. And as you are obese, overweight, your diet is also not very good control, and you are not able to control your diet, the best option for you will be the GLP-1. And we explain the patient, and before starting that, for 5 to 6 days, we have done the simple continuous glucose monitoring, putting him only in 0.75 to start with. And then after 5-6 days, we had seen that his sugar started coming down, and then we had decreased the dose of even sulfonylurea metformin, and this patient is only on metformin and sulfonylurea after a couple of weeks, and patient sulfonylurea dose continuously decreased, and sugar is absolutely well controlled. And later on, we added this patient on SGLT2 inhibitor also. So this is Mr. Nirav Sanghvi, absolutely well-controlled diabetes only with the help of GLP-1, not adding any other molecule, not added insulin. There was a weight reduction. There is a lifestyle modification also improved because of GLP-1, and his sugar get absolutely well controlled. This is one very, very interesting patient, and I always try to show that how guideline and how clinical practice is actually changed. The guideline, according to a patient who is on a triple drug, glimepiride, metformin, and gliptin, the patient had come to us with a very high sugar with 9.5 and had gone to two other diabetologists, endocrinologists too, and everyone advised him to start on insulin. And that's very true. As per the guideline, the patient who is very uncontrolled diabetes with a triple drug oral anti-diabetic agent, there is no choice, that patient has to be on insulin. What we explain the patient, let us do your continuous glucose monitoring, AZP Libre Pro we put. After 5 days, we call the patient, we explain that yes, your fasting, post-meal, everything is high. There is a choice of putting you on insulin, or the other choice is putting you on GLP-1. And I see that you are not very good in your diet control, and as you are obese also, I would like to put you on GLP-1 and SGLT2 both. We will stop your DPP-4, and probably your glimepiride also I will reduce, because patient was taking 2 milligram twice daily, and what we have done is 2 milligram instead of that 1 milligram twice daily. And every alternate day patient has to call us. On 6th day we started him. On Thursday, first PAP, patient called us, and we decreased it from 2 milligram to 1. Again, after 3 days, on 4th FAB, patient called us. The sugar was well controlled. Even it was AZP, so retrospective data, but patient was doing self-monitoring as we asked them. And on 4th Feb, it was made only 0.5. When patient had come on us on 4th Feb, we had shown that, see, your sugar is absolutely well controlled, and let us now stop your sulfonylurea, and you will be only on metformin and SGLT2 with injectable GLP-1, and you can see the patient sugar was absolutely well controlled. So the guideline is explaining us that a patient with an uncontrolled diabetic should be directed for insulin therapy. That is what the guideline is saying with a 9.5. But an individualized patient to whom you can monitor them with like a continuous glucose monitoring, then motivating him, educating him, changing his diet pattern, nutrition, and with the drugs which can be more effective to get a good control of diabetes. You can see here the flat line is coming without adding insulin or without increasing the dose of the medication. Now the patient is only on metformin, SGLT2, and with GLP-1.
So CGM is recommended in adults with children with type 1 diabetes, adults with type 2 diabetes, receiving insulin, sulfonylurea, glenites, patient with hypoglycemia unawareness, and those with irregular schedule, and supplement to blood glucose monitoring in GDM. CGM can also be used to educate patients to understand their diabetes better, take ownership towards managing their lifestyle, improving their glucose control. CGM should be considered in conjunction with SMBG and SPC for glycemic status assessment in type 2 diabetes individual who are treated with intensive insulin therapy who are not achieving glucose target. The glucose modification, guideline modification for South Asian population include change in the lower limit of time in range, high risk population, upper limit of time above range, and flexibility in the percentage of time spent in time above range for pregnant women with GDM or with type 2 diabetes. With this, I thank you to HiDoc for this recording, and thanks to Abbott and RSDI for giving me this opportunity. Thanks all the participants. Now I will be very happy if there is any question. You can post your question in chat box as well as live also. Thank you.
Yeah. So thank you, doctor. So here are a few questions for you. So out of which the first question is, when do you recommend CGMs in which patient profiles?
So you are talking of type 2 and type 1. There are two different varieties of patient. Type 1 diabetes, actually speaking, each and every patient we can recommend type 1 diabetic patients. For type 2 diabetes patients, again, those who are on sulfonylurea, insulin, who should be monitored more frequently. Risk of hypoglycemia is more common with them. They are the one who should be again on continuous glucose monitoring. Now we know that the cost for monitoring, particularly continuous glucose monitoring for each and every type 2 diabetic may be very high. So what we do is, if patient, which I had shown in my some of the clinical cases also, like you are finding some patient whose sugar is finding every time high and HbA1c is also very high, and you are trying to increase the dose of medication and you are finding that person is developing actually hypoglycemia. So you want to titrate the dose in such a way that they should not increase the risk of hypoglycemia. At the same time, the glycemic variability also decreases and patient reaches a plateau in a very smooth manner with the fasting is coming absolutely well controlled without hurting hypoglycemia. They are the ideal patient to start with a continuous glucose monitoring. But I do use continuous glucose monitoring in a different type of type 2 diabetic patients, even for nutrition counseling, even for patients with pre-diabetes, also to teach them, educate them for how the post-meal glucose can be controlled with the small portion of carbs and more complex carb and more giving protein and fiber. The similar way, a patients to whom I want to start them on a GLP-1 and to explain them, now this is not the time when you have to start with insulin, better will be the GLP-1. So, in different varieties of patient, we can use the continuous glucose monitoring. Rather, I will say in last 5 years, our practice is completely changed. It's a lot of paradigm shift had happened because we were chasing only the HbA1c. Now we know that it is not only the HbA1c which is important. It is the continuous glucose monitoring, the glucose profile, the time in range. These are the parameters which are more important, and we should try to achieve them. We should try to aim to achieve a tight glycemic control after putting them on a continuous glucose monitoring. But definitely, the cost is a challenge, and how you explain the patient. I think bigger challenge is not the cost. Probably the bigger challenge is how we communicate to the patient, to teach him, educate him that how it can be more effectively used and how it is going to help you to achieve a good control of diabetes. So these are the some of the examples also I had given in my presentation, some 5-6 different varieties of patients where we use not even this Libre, we had used Libre Pro, where we had utilized the same 14 days graph for 2 or 3 times to consult the patient in between, and we had optimized the therapy and achieved a tight glycemic control.
Yes, thank you, doctor. So the next question which we have is, how do you take care of dietary changes and lifestyle changes in people with diabetes?
So it is again education. You explain the patient once in a diet. Most of the patients, they understand the dietary. Even after you explain them everything, they say yes in front of you. But many of the times they don't change their dietary pattern. So it requires continuous education. Every time when patient comes, you have to teach, educate them regarding the diet which you had asked for, and you ask for a specific diet, and then you have to understand from the spouse also whether that person is taking or not. So the diet compliance is really poor. That's the reason we should educate the persons more and more for that.
Okay, so one more question we have got. Is there any better option than HbA1c? And if it is, then why?
The better option is continuous glucose monitoring. So I will not go with the average A1c of last 3 months. If given a choice, I would like to have a continuous glucose monitoring data, which will give me a much better how the profile is, variabilities, where person is developing hypo, how much time is remaining in range, how much time patient sugar goes up and low. So I think the better reliability indicator is definitely continuous glucose monitoring.
Okay. What are the few must to counsel points for patients whom you recommend CGMs?
So you are asking what are the points which I should discuss with the patient?
The question is, what are a few must to counsel points for patients
so
whom
few
you
must
recommend
is,
CGMs?
the few must is, one is we explain the patient that how, a continuous profile. It's like a videography. It's not the still photography. So when you are taking a still photograph, you will always find a person is in a smiling face, would like to give you a photograph which can be posted at one of the social media. While if you are taking a continuous glucose monitoring, like a videography of that person, you will know his complete activities since morning to evening. And then you will find that how much time he's actually remaining in happiness, smiling, or otherwise he is also depressed in between. So those type of things you can only get through continuous glucose monitoring. And this we explain the patient that how CGM can be important, because glucose is a constantly changing in your body. And then you know that when you are taking the food and you are finding suddenly your sugar is increasing, and then this will also give you education what type of food was responsible for your increasing sugar so much, and that will also help you for that.
Yes. Also, doctor, what is the first line treatment on first time detection of diabetes?
First time treatment after detection of first time diabetes, maybe
Diabetes.
starting with metformin, or then you can always add either SGLT2 or DPP4 for better control.
Okay. We have one question coming up, that is, due to increase in blood volume, etc., in pregnancy, how much reliability of HbA1c will be in different trimesters of pregnancy?
So I agree with you that A1C is not a great marker of average for pregnant lady, and we always go with the self-monitoring of blood glucose where we rely more, but we definitely do with the first trimester just to understand whether it's a true GDM or pre-gestational diabetes. Because those who have high A1C even in the first trimester, it means they were already diabetic before they become pregnant. So that's number one. But sometime to monitor, just rough monitoring, we don't rely on it, but roughly monitoring these patients can be done HbA1c. Then we do continuous glucose monitoring, that is also with interstitial fluid, which also shows slightly more hypoglycemia, but still it is okay because we wanted to know the profile as well as the behavior pattern of the glucose level. Glucose pattern is more important sometimes, and for that reason we do the continuous glucose monitoring also.
Yeah. Doctor, what is the ideal OHA glucose monitoring implants and its reliability?
So ideal OHA means we start with the same metformin, SGLT2, DPP4, all those things. And what you are saying is, what is the reliable way of monitoring these patients?
Correct.
The self-monitoring, HbA1c, and continuous glucose monitoring. I put all these three are complementing actually each other. At this point of time, I can't say that you can replace after CGM. Now there is no need for SMBG or no need for HbA1c. But most of the patients are not doing. So sometimes we are using intermittent, using this continuous glucose monitoring. In between, we do HbA1c also, and plus ask the patient to do SMBG regularly.
Okay. How do you see the future of immunotherapy of type 1 diabetes?
So type 1 diabetes, very early detected diabetic patients, type 1, they had given the immunotherapy and found to have some good results. I was also one of the clinical trial for immunotherapy for a newly detected diabetes. In our patients, most of the patients are late diagnosed and they are not ready for such a costly therapy even after we teach them. So it's really difficult because to get the patient in clinical trial was also very difficult for them.
Okay. And which guidelines, according to you, best suits in the clinical practice?
It's always RSGA clinical practice recommendation.
Okay. So I'm checking if there are any more questions, I guess. Yes. So I guess we have one more question up. Okay, so what is your take on bariatric surgery for weight loss in obese diabetic patients?
I do recommend the patients who should go for bariatric surgery with BMI more than 30, with diabetes, and who are routinely not controlled with routine anti-diabetic agents. They should be given choice.
Okay. We have a few more questions coming up, doctor. Is blood sugar monitoring without diabetes worthwhile? If yes, what are its indications?
No. So,
okay, so what are his indications of this?
There are people who are doing in pre-diabetic population. There are some of the apps who are trying to do it even in a non-diabetic population also. But I found it is of no use.
Okay. How do you teach people with diabetes how to use CGM device? And are there any safety considerations for the use of?
Safety considerations are not many. That is not a major challenge for us. The only thing is some of the patients, other than cost, they are worried of something is constantly touching their body or it will be attached with them. Some of them are worried it is actually surgery and then you are going to put. So we have to explain this is a sensor. It is just putting on your skin. It will not cause any problem. But some of the patients may have a problem of there is a itching they are feeling after 2-3 days. They feel something which is difficult. Night time they can't sleep with this. So there are some patients who are a bit fussy, but otherwise once you explain them properly, most of the patients does not have it.
Okay. We have a question. How do you manage cases of brittle diabetes?
So brittle diabetes is a term which was used when we were using with increasing 1 or 2 units here or there, or decreasing 1 or 2 units, the sugar used to fluctuate like anything. I think the continuous glucose monitoring had really answered this brittle diabetes properly. Now I can say after using CGM, I will not put the diagnosis of brittle diabetes because I can always change the therapy in such a way that patient sugar will be absolutely well controlled.
Okay. And how do you manage the cases of this brittle diabetes?
Putting them on CGM and taking them more continuously, the correction dose shots, and accordingly we do it. And most of the patients are now no more brittle diabetes.
Okay. And what is the ideal time to put patient on CGMS?
I mean, as soon as you can explain the patient and as soon as patient accept it.
Okay. So, well, I feel we have almost taken up all the questions, doctor. So
Thank you.
I
Thank you,
really
Anand.
thank you.
Thank you,
Yeah.
separately. Thank you.
Yeah. So first of all, I would like to thank you, Dr. Bansi Sabu, for enlightening all the doctors with this insightful session. Also, I would like to express my heartfelt gratitude to all the members present today and thank you for your patient listening.